Assalamu alaikum. I would like to welcome you back to Echoeducation. This is Read with Expert sessions. In this session, we will go over 5 echocardiographic cases in which we will try together to reveal the important echo findings with its anatomical and hemodynamic significance. Question number 1. What's your diagnosis? So this is a short axis view and modified apical 4-chamber view. So here in this short axis, this is at the level of the mitral valve, and you can see there are 2 orifices for the mitral valve. From the apical 4-chamber, you can see that there is double inflow of from the left atrium to the left ventricle. So this is double orifice mitral valve. It will be quite clear when we have the color Doppler across the mitral valve. So here, this is the inflow from the left atrium to the left ventricle, and you can see here the 2 envelopes for the color envelopes here between the left atrium and the left ventricle, and there is some flow acceleration. This is the short axis view. You can see here there are more than 2 papillary muscles. In this case, we have 3 papillary muscles. So one of the mitral valve here is attached to 2 papillary muscle, and the other one is attaching to 1 papillary muscle. So the second smaller orifice is a parachute. Question number 2. What's your diagnosis here? So this is a parasternal long axis view showing the left atrium, and this is the mitral valve, this is the left ventricle, and this is the interventricular septum. And you can see here there's a clearly ventricular septal defect. This is the right ventricle, this is the left ventricle, and this VSD is quite a large VSD. Why it's large VSD? Because the VSD here is as big as the aortic valve, so it is by definition a large ventricular septal defect. From this modified parasternal short axis, you can see that the VSD is in between the pulmonary valve and the aortic valve in this area. So this is a ventricular septal defect, and it is a doubly committed ventricular septal defect. The second part of the question, define the surgical approach of repair. So how does the surgeon repair this ventricular septal defect? So here, this is the doubly committed VSD with a color. You can see there is a left to right shunt, and this is unrestricted flow between the left ventricle and the right ventricle. And here it's very nice, showing also the VSD in relation to the pulmonary valve. So this is subpulmonary or doubly committed ventricular septal defect. Usually the surgeon will approach this VSD repair through the pulmonary valve. So they open the pulmonary valve and then try to suture and patch the VSD without opening the right atrium, and is not going through the tricuspid valve. The third question here, mention 2 important findings. This is apical 4-chamber view, and this is parasternal short axis view. As you can see here, there is a hugely dilated right atrium, dilated right ventricle, and also the right ventricle is depressed in function. And when you look at the interventricular septum, it's deviated towards the left side. So this ventricle is volume and pressure loaded. When we look at the parasternal short axis, what do you notice here? We notice that there is, first of all, there is a significant tricuspid valve regurgitation, but here in the perimembranous area, we start to see there's a shunt, and this shunt is actually bidirectional. It's left to right, where you can see the red color, and it is right to left, where is the blue color here, and it's right to left in systole. So this patient has perimembranous ventricular septal defect and almost suprasystemic right ventricular pressure. This is the same patient. We are looking from apical fourth chamber with a color, and you can see there's significant tricuspid valve regurgitation, and here there is also there is a pulmonary valve regurgitation and dilated pulmonary arteries. When we look carefully at the perimembranous area, you can see there's a defect here, and the tissue in the perimembranous area is shifted towards the left ventricle. That means the right ventricle has a higher pressure. And this is with the color. You can see the bidirectional shunting with the right to left in systole and left to right in diastole. So what's the next investigation for this patient? We need to categorize his pulmonary hypertension and measure the PA pressure with the pulmonary vascular resistance. So we need a cardiac catheterization. This is the fourth question. So here, this is apical fourth chamber. You can see the left side of the heart is almost normal, but when you look in the right side of the heart, you will see that the right atrium is dilated and large, and also the tricuspid valve is displaced downward here. So this is actually a severe form of Ebstein anomaly. We will know about the components of the tricuspid valve when we have the color Doppler in place. But here, this is the same patient with parasternal long axis. What do you notice here? We notice that there is a small ventricular septal defect with a left to right shunt. But also, if you look carefully, you can see that the aortic valve cusps is pushed into this ventricular septal defect. So the two important findings, we have an Ebstein anomaly, as well as we have perimembranous ventricular septal defect, and also we have prolapse of the aortic valve into the ventricular septal defect. The question is, what is the surgical time plan? So this patient has significant tricuspid valve regurgitation, which is expected from his Ebstein. Also, this patient has prolapse of the aortic valve into the VSD, so this patient needs elective surgical repair for his Ebstein anomaly, as well as VSD closure and plus or minus aortic valve repair. This is the last echocardiographic case. I would like you to look carefully here and tell me what's the name of the surgical procedure done for this patient. So this is actually a long loop. So we start here showing subcostal view, showing the left atrium and the right atrium. So at the beginning of the loop, you can see the right-sided pulmonary vein is draining into the left atrium. And at the end of the loop, you can see that here there is a flow acceleration from the SVC to the right atrium with obstruction. So what is the name of this surgical procedure? This surgical procedure is called Warden operation, in which it is used for patients with these patients. Usually they have sinus venosus ASD, and they have partial anomalous pulmonary venous drainage into the SVC. So in this case of repair, they utilize the lower part of the SVC as the tunnel for the pulmonary vein into the left atrium, and then they connect the SVC into the right atrial appendage. And this procedure, usually it results in SVC obstruction, and nowadays they are not doing this procedure anymore. They are trying to repair the pulmonary vein and the SVC without a Warden procedure. So this is the same patient, and they have, because the patient has SVC obstruction, they placed, this is the same patient, they have placed stent into the lower part of the SVC, and you can see that the SVC stent is also reaching to the right atrium to establish good flow between the SVC and the right atrium. And the last, I will leave you to enjoy my nature and heart collections. Thank you.